The management of ductal carcinoma in situ. Understanding the modern approach to ductal carcinoma in situ. Welcome to our in-depth podcast episode where we explore the management of ductal carcinoma in situ, often called stage 0 breast cancer. Today, we will guide you through what ductal carcinoma in situ is, why its management is so important, and how treatment decisions are made in a way that is tailored to each individual patient. Introduction. Ductal carcinoma in situ, or ductal carcinoma confined within the milk ducts, is a unique form of breast cancer. It is considered a non-obligate precursor to invasive breast cancer, meaning not every case will become more serious. In this condition, abnormal cells remain within the lining of the breast duct and have not broken out to invade nearby breast tissue. Because it cannot spread to other parts of the body, the outlook is excellent with proper treatment. In fact, the survival rate for breast cancer specifically is close to 99%. The central goal in managing ductal carcinoma in situ is to prevent it from becoming invasive breast cancer. This is not a one-size-fits-all approach. It requires collaboration among specialists such as surgeons, medical oncologists, radiation oncologists, radiologists, and pathologists. Most importantly, the patient's values and preferences play a critical role in deciding the most appropriate course of action. Key elements in the management of ductal carcinoma in situ. The mainstay of treatment is local therapy, which typically involves an operation, sometimes followed by radiation and hormonal therapy. The overall strategy depends on several factors, including the size and extent of the tumor, as seen on imaging and confirmed by pathology, the grade of the cells, which may be low, intermediate, or high, whether there is dead tissue, known as comedonecrosis, how close the tumor is to the edge of the removed tissue, referred to as the surgical margin, hormone receptor status, such as the presence of estrogen or progesterone receptors, patient-specific factors, including age, menopausal status, family history, genetic mutations like BRCA, and personal preferences. Surgical management. Surgery is the foundation of treatment for ductal carcinoma in situ, with two main options to consider. The first is breast-conserving surgery, commonly called a lumpectomy. In this procedure, the surgeon removes the area of ductal carcinoma in situ along with the surrounding rim of healthy tissue. The aim is to achieve what is called a negative margin, meaning no cancer cells are found on the outer edge of the removed tissue. Current guidelines recommend a margin of 2 mm to minimize the chance of the cancer returning to the same area. Most women who have this surgery will also have radiation to the whole breast afterward to reduce the risk of recurrence. Breast-conserving surgery is usually suitable for women with a single, localized focus of disease. The second surgical option is mastectomy, which involves removing the entire breast, sometimes including the nipple. This approach is chosen when the area of ductal carcinoma in situ is large compared to the breast size, when there are multiple areas in different parts of the breast, when it is not possible to get clear margins after several attempts, or when the patient strongly prefers it, such as in those with a significant family history or who wish to avoid radiation. Mastectomy offers the lowest risk of the cancer returning, but in terms of overall survival, it is generally equivalent to breast-conserving surgery plus radiation for most patients. Sentinel lymph node biopsy. A common question is whether lymph nodes should be checked at the time of surgery. In cases where breast-conserving surgery is performed for pure ductal carcinoma in situ, sentinel lymph node biopsy is usually not done because the disease has not spread. However, if the entire breast is being removed, a sentinel lymph node biopsy is performed at the same time. This is important because, in about 10 to 15% of cases, the final examination of the tissue may reveal a small area of invasive cancer that was not seen before surgery. Once the breast is removed, it is not possible to map the lymph nodes, so this step is taken as a precaution. Radiation therapy. After surgery. Radiation plays a key role after breast-conserving surgery. Its main purpose is to reduce the risk of the cancer coming back in the same breast, whether as ductal carcinoma in situ or as invasive cancer. Several large clinical trials have demonstrated that adding radiation after surgery can lower the risk of recurrence by about half. The standard course involves treating the entire breast over 3 to 6 weeks. However, there is growing discussion about whether radiation can be safely omitted in select patients who are at very low risk. These are usually women over the age of 50 or 60, with small, low to intermediate grade tumors, and wide clear margins. If radiation is not given, the risk of local recurrence rises modestly, from about 5 to 10% up to about 15 to 20% over 10 years. but many women feel this is an acceptable trade-off to avoid the side effects of radiation. Endocrine therapy. Hormonal or endocrine therapy is considered for patients whose ductal carcinoma in situ is positive for estrogen or progesterone receptors, which is the case in about 80% of patients. The goal is to reduce the risk of future breast cancer events, both in the same breast and in the opposite breast. Tamoxifen is frequently used in both pre- and postmenopausal women and has been shown to lower the recurrence risk by 30 to 50%. Aromatase inhibitors, such as anastrozole or letrozole, are options for postmenopausal women and may offer a slight advantage over tamoxifen in certain circumstances, though the side effects differ. The decision to take hormone therapy is based on the balance between the benefit, which is often a 5 to 10% reduction in risk over 10 years, and potential side effects like blood clots or bone thinning. Special considerations and emerging trends. There are some newer areas of interest in the management of ductal carcinoma in situ. The Oncotype DX ductal carcinoma in situ score, a genomic test, can help estimate the risk of the cancer returning over 10 years and can inform the decision about whether radiation can be safely omitted. In addition, ongoing clinical trials are exploring whether it is safe to observe some cases of low-grade ductal carcinoma in situ with regular monitoring rather than immediate surgery, following a model similar to that used in some cases of prostate cancer. However, this approach is not yet standard of care. Genetic testing is also important for some women, especially those with a strong family history of breast or ovarian cancer or a diagnosis at a young age. If a mutation such as BRCA is found, it may influence the choice of surgery. Conclusion. To sum up, the management of ductal carcinoma in situ is a model example of personalized medicine. There is no single correct answer for every patient. The best approach results from a thoughtful conversation between the patient and her team of specialists, weighing the estimated risk of recurrence against the benefits and possible side effects of additional therapies. The excellent outlook for ductal carcinoma in situ allows for careful, individualized decision-making, always keeping the patient's values and preferences at the center of care. Thank you for joining us for this formal discussion on the management of ductal carcinoma in situ. We hope this episode has helped clarify the various options and considerations in this evolving area of breast cancer care. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.